Hello and welcome to Billing for the Female Condom. Presenting on the webinar today, we will have Amanda Kimber Kellenson, Director of Healthcare Delivery at the National Family Planning and Reproductive Health Association, and myself, Rebecca Horowitz, the State Policy Manager at the National Coalition of STD Directors. Now to dive into our content for today, I will start by providing the background on how we got to where we are today and the reason that we are hosting this webinar. For years, cost has been cited as a significant barrier to obtaining birth control for many women. As a result, during the healthcare debate and ever since, measures have been taken to lower the cost of birth control and therefore minimize this access barrier to contraceptive methods. With the passage of the ACA, starting on August 1st, 2012, there were significant changes to minimize this barrier. At this time, all non-grandfathered private plans were required to cover preventative services without charging patients a co-payment or co-insurance. In 2014, only 26% of workers covered in employer-sponsored plans were still on grandfathered plans, and it is expected that over time, almost all plans will lose their grandfathered status. So how does it work? The ACA mandated that plans must cover all FDA-approved methods of contraception starting in August 2012. This is because contraceptive methods and contraceptive counseling are included as part of women's preventative services. So all women with reproductive capacity have access to all Food and Drug Administration or FDA-approved contraceptive methods, with the exception of women who are participants or beneficiaries in group health plans sponsored by religious employers. This is true even if the patient hasn't met his or her yearly deductible. In 2013, this mandate of contraceptive coverage was reiterated and expanded through clarifying language that plans must cover a full range of FDA-approved contraceptive methods. Then, in 2015, there was further clarification that plans must cover at least one form of contraception in each of the 18 method categories. Plans can use utilization controls within methods, but not between. Plans must also provide its members access to an off-formulary contraceptive if medically indicated. The FAQ explicitly states that providers' opinion trumps plan rules on method restrictions. So this includes condoms, male and female, as contraceptive methods that should be covered under all non-grandfathered plans. But because condoms generally, and female condoms specifically, are contraceptive methods that individuals are used to receiving over the counter, and in many cases for free from clinics and providers, and not by prescription, this may require a change in thinking for providers, patients, and pharmacies. Amanda will be explaining how the reimbursement and prescription process works in a few minutes, but first, I wanted to highlight the new resources that NCSD and NIFRA created to address coverage for the female condom. We created a palm card for patients to tell them about coverage for the female condom and how the female condom may be free for them, either through their provider getting reimbursed for the female condom or they're taking a prescription for the female condom to their local pharmacy counter. This piece is designed to start the conversation and get patients informed about and more comfortable with the female condom and how they might be able to get it for free under the ACA. The second resource that we created was a fact sheet, which covers more in-depth information for providers on how to write a prescription and how to seek reimbursement for the female condom. Both of these pieces are available for download on NCSD and NIFRA's websites, and hard copies are available from both of our organizations if you're interested in getting hard copies for your waiting rooms or elsewhere in your clinics or health departments. I'm now going to hand it over to Amanda from NIFRA.
Thanks, Rebecca. So I wanted to take this time to quickly walk through some of the useful information that you would want to acquire in order to bill for the female condom. If you currently do not bill for the female condom, it's beneficial to start the process by confirming coverage with the individual payers you already bill. If you do not bill, it's a good idea to look at documents that the plan offers you if you're going to start down that path. You'll need to review the contractor fee schedule to ensure the female condom is listed as a covered service. In addition to identifying whether it's a covered service, you'll want to also request specific guidance from payers on the following aspects related to billing. You'd like to look at the reimbursement rate per unit, a definition of the unit, whether a unit equals 1 condom or whether a unit equals 3 condoms. You'd want to look at whether there's a maximum limit on the number of units you can bill per claim, and whether there are any applicable dispensing fees that you can bill in addition to the units themselves. And finally, you'd want to look at whether there are any applicable payment limits, so that would be the cost of the female condom plus a dispensing fee, and whether there is a limit on how much that can equal. And finally, whether there is a frequency limitation and whether there is an interval between when you can bill for your patient. After that, you'll want to confirm the appropriate codes that payers require. This includes CPT codes, HCPCS codes, and the diagnosis codes that you would need to use to accompany those procedure or device codes. The fact sheet that Rebecca mentioned earlier included the suggested codes, and I'll show them to you in a few slides. But always remember to confirm them with your payer, as they can vary from one payer to another. So these steps should prepare you to submit a claim, and hopefully it works. If not, you'll need to go through the denial management process, and we've prepared a few slides to help you troubleshoot common denial scenarios. In the first scenario, the patient receives the method from the provider. That's often case you or one of your grantees if you are a grant administering agency. In this case, you'll submit a claim for reimbursement and the claim is denied. If those of you on the phone bill, you'll likely be familiar with this course of action to help remedy the problem of payer denials. I'll run through this scenario first and then discuss how you can help your patients who face problems getting female condoms at pharmacies. First, you'll want to identify whether a plan is a grandfathered plan. These are plans that are required to adhere to contraceptive coverage requirements in the ACA. The National Women's Law Center has an excellent flowchart to help you and your patients identify whether the plan in question is required to cover the methods that Rebecca discussed earlier. And we have a link for this flowchart at the end of the presentation, as well as links to other useful resources. So if the answer is yes, when you use this flowchart, the female condom must be covered, and you can move on to the next step in the process, which is putting together documentation to help in the appeal process. Both you and your patients can and should file appeals with the payer in the event that they have issued a denial for claims. Here's an excerpt of a letter written by the National Women's Law Center that you can use in your appeals letter. Again, there's a link at the end of the presentation so you can look at a sample appeal letter to help your patients in the process. Your payers often need a reminder that contraceptive methods must be covered without cost sharing, and these are useful tools to give them that reminder. And finally, as I mentioned earlier, you want to confirm that your HCPCS and ICD-10 codes are appropriate in the claim that you submitted to the payer. So here are some suggested codes, but again, you always want to confirm the codes with your payer. Although if you do notice that they are requiring you to use codes that seem to not be appropriate for that method, you should document any of these discrepancies and raise concerns with the payer. Now, let's visit the second path that patients follow in order to obtain female condoms, and this is from a pharmacy. In this troubleshooting scenario, the patient has attempted to use her insurance coverage to obtain the female condom over the counter at a pharmacy. This could raise a variety of issues. The pharmacist may not stock the methods. They may not know how to bill for the method because it is an over-the-counter method, or they may refuse to bill for the service, or the claim may be denied in the event that the pharmacist agrees to bill. We've put together a few tools to help you and your patients in this scenario. First, it helps to educate your local pharmacist on the various contraceptive methods that should be available over the counter as a means to ensure your patients have ready access to them. You should consider providing NDC codes for the methods as a way to help streamline stocking. If you're not familiar with the NDC number, we've included the FDA directory shown here. There's a link to it at the end of the presentation. And the NDC codes for the female condom are listed on our fact sheet. Next, you should empower your patients to help themselves by educating them on the contraceptive coverage requirements that their plans must adhere to. We have a patient palm card included in our toolkit that we've made for you, and this briefly spells out the contraceptive coverage requirements in patient-friendly language. I also encourage you to check out the National Women's Law Center website for more tools, which we've included a link to at the end of the presentation. Finally, even though your patient does not need a prescription for these methods, it may help to write a prescription for them. This has been shown to help clarify things with pharmacists when patients come in with a prescription in hand. We've included a sample prescription here. Next, we wanted to give you 2 examples of case studies of providers who have successfully billed for dispensing a female condom and who have also successfully written a prescription. So the first one is a family planning provider in Wisconsin. Wisconsin state health official has been a long proponent of dual protection to prevent STDs and unintended pregnancies. So the state of Wisconsin, when it implemented its 1115 family planning waiver in 2003, included initially female condoms on the fee schedule for provider reimbursement. The reimbursement rate for the female condom is $3.44, as it always has been on the fee schedule for Medicaid. It is reimbursable as a medical benefit, and providers in Wisconsin do not need to drop a pharmacy benefit claim to request reimbursement. The providers used to be required to use a CPT code 99070 for both male and female condoms, but Medicaid now has the ability to accept the HCPCS codes A4268 and A4267 for female and male condoms, respectively. So we can document that family planning providers in Wisconsin are successfully submitting claims to Medicaid based on these details. Now I'm going to turn it over to Rebecca to discuss a provider who writes prescriptions for a female condom.
Thanks, Amanda. This is just a little tidbit of a story a nurse practitioner student in Massachusetts told me. She's been working in both a family planning clinic and a Planned Parenthood clinic, actually, and a community health clinic. And in both contexts has been offering prescriptions for the female condom. And in both cases, in both settings, the audience, the women that she's offered the female condom to, had been fairly uninformed about the female condom and were completely uninformed about the availability of the female condom for free, either through a prescription or through the provider being reimbursed. So what she found was that there was a lot of excitement from the patients. A lot of them thought that a few of them thought the female condom actually wasn't available anymore, and it is a method that she was really excited about and was really excited to hear that it was still available. In every case, the patient took the prescription and was excited by the opportunity to take it to their pharmacy. Because this is a student, she doesn't have the long-term relationship with the patient to know whether or not they successfully took the prescription to their pharmacy and were able to get it filled. But we can give at least the commentary that her goal was to assess interest from patients and the acceptability of taking a prescription for the female condom, and the response to that was very strong, and people were very interested. And the fact that the condom is not typically something that you would take a prescription for didn't seem to be something that was off-putting to them.
Thanks, Rebecca. Finally, we wanted to provide the links to the resources we mentioned earlier in the presentation, and this presentation will be available online, and so you can access these links at a later date. Finally, we encourage you to contact us with any questions or concerns you have about billing for the female condom. And our contact information is available online and on the screen right now. So I want to take this time to thank our partners at NCSD, particularly Rebecca, for this presentation today. And of course, we want to thank the Female Health Company for their support in creating the materials that we have available at NCSD and NIFRA, and for the underwriting of this presentation today.
Thank you.